The COTC March algorithm is not a checklist. It's not a memory aid. It's not a mnemonic for pneumatics to keep the steps in order. It is a priority hierarchy built from 2 decades of combat casualty data that ranks the causes of preventable pre-hospital death in descending order of how fast they will kill your patient. And most civilian first aid courses teach it backwards because they do not understand the math underneath it. Today, we fix that. I'm Dr. Marco Torres. This is Talking TACMED, episode 5. We have talked about tourniquets. We have talked about packing. Today, we talk about the framework that tells you which one to reach for, in what order, when you arrive at a scene with a patient who has multiple problems at once. MARCH, M-A-R-C-H, massive hemorrhage, airway, respiration, circulation, head injury, and hypothermia treatment. Every letter is a category of preventable death. The order of the letters is not alphabetical. It's not arbitrary and not random. The order is time to death, rank. M kills fastest. H is managed last because if you have not fixed M, A, R, and C, there is no H to worry about. If you understand the order and why it is the order, you will make the correct first decision at every trauma scene you ever respond to. If you do not understand it, you will do what most trained civilians do, which is start at breathing, because that's where 30 years of CPR training has put their hands, while, of course, your patient bleeds to death 6 inches away. Let me walk you through the time math for each category. This is what the order is built on. Let's start with M, massive hemorrhage. A severed femoral artery exsanguinates an adult in approximately 3 to 5 minutes. Some reports from combat medicine put it closer to 2, but we'll stick with 3 to 5 for now. The body loses roughly 30% of its 5-liter total volume. This is going to be about 1.5 liters before compensation fails. After that, perfusion to the brain collapses, and the patient loses consciousness, and of course, cardiac arrest follows within another couple of minutes. Time to death, as fast as 3 minutes. Then we move on to A, airway. An adult with a complete obstructed airway reaches hypoxic brain injury at around the 4-minute mark. Irreversible injury at 6. That's the kind we just can't come back from, where you have permanent brain damage. Cardiac arrest will follow somewhere in the 6 to 10-minute range, depending on pre-event oxygen saturation and the patient's own physical condition and metabolic state. Time to death, roughly 6 or 10 minutes, give or take. R, respiration. So this is where tension pneumothorax lives. A penetrating chest wound creates a one-way valve. Air in, no air out. And then pressure will build in what's called the pleural space. The mediastinum, all of the structures that are found in the center of the chest, the heart and some of the great vessels, will shift. Speaking of which, the great vessels will kink. If the great vessels kink, there is decreased blood flow return to the heart and cardiac output drops. Time from injury to cardiovascular collapse is typically 10 to 15 minutes, sometimes longer. Time to death, also 10 to 15 minutes, sometimes 20. C for circulation. So this letter is about shock, perfusion failure from any of the above, or from ongoing internal bleeding that you can't see or control in the field. Now, without intervention, moderate shock can progress to severe shock over 20 to 60 minutes, best case scenario, give or take. Time to death is variable, but usually 30 minutes or more. H for head injury and hypothermia. Now, you can have expanding intracranial hematomas, bleeding into the brain, that can kill over hours, not minutes. Hypothermia worsens bleeding and acidosis. It's called the lethal triad, but on a time scale of hours in a field environment. Time to death, possibly an hour or more. Now, if you line up the order, 3 minutes, 6 to 10, 10 to 15, 30 plus, an hour plus. Now, again, the sequence is not a checklist, it is a ranking of urgency. The fastest killer goes first. Now, Conti published the current March structure based on combat casualty data from 2 decades of Iraq and Afghanistan operations. The Joint Trauma Systems, the Prolonged Casualty Care Guidelines carry the same framework forward for longer evacuations timelines. The NAS EMS SO model guidelines incorporate the priority structure into civilian EMS protocols in most U.S. jurisdictions. The doctrine is consistent across every authoritative source. Massive hemorrhage before airway, every time, no exceptions. Here is where civilian training breaks down. Now, most civilian first aid courses, including many CPR and AED programs, teach a variant of the old ABC sequence: airway, breathing, circulation. That framework was written for cardiac arrest in a hospital or at home, where the dominant cause of death is a heart problem, not a bleeding problem. So when you apply ABC to a trauma scene, you do it backwards. You go to airway first, you tilt the head, you check breathing, you start compressions. Meanwhile, the arterial bleed in the patient's thigh empties them into the patient. March inverts that. For trauma, any scene where penetrating injury, like a vehicle collision, a fall from height, or violence, is the mechanism, massive hemorrhage is the first check. Always. Before you touch the airway, before you look for breathing, before you do anything else. The reason civilian courses often teach it wrong is not malice, it's simplification. ABC is easier to teach in a 2-hour class. March requires the student to understand which letter applies to which patient type, and that requires mechanism of injury thinking that most courses skip. The cost of that simplification is that the framework works fine for cardiac arrest and fails for trauma. And trauma is the scene a prepared civilian is most likely to walk into. The CONSI recommended doctrine is clear. Trauma scene. March, M first, always. Now let's talk about a specific scene. Highway collision. Single vehicle. The car hit a bridge abutment at roughly 55 miles an hour. Driver is in the seat, unconscious, slumped to one side. You are the first civilian on the scene. You can see blood pooling on the floorboard by the pedals. His face is slack, and you cannot tell from the outside the car whether he is breathing. The untrained instinct is to get him out of the car, tilt his head, check for breathing, start CPR. That sequence kills him. The March sequence looks at it like this. M. Before you touch anything else, you find the bleeding. You open the door, you look at the floorboard, you follow the blood trail up to the source. Is it from the leg, the abdomen, the neck? If it's from a compressible extremity and you can see it, you apply a tourniquet, even inside the vehicle, before you do anything else. This is the correction. Bleeding first. A. Now the airway. An unconscious patient with their head slump will have their tongue potentially occluding. You perform a jaw thrust maneuver, not a head tilt, because you are assuming potentially, again, a C-spine injury in a high mechanism, high force collision. The jaw thrust will open the airway without moving the neck. If he is breathing, you maintain the airway in 1. Speaking of which, R. Is he breathing adequately? Is there a sucking chest wound? Inspect. Look, listen. If there's a penetrating chest wound, that is a chest seal problem, and we will cover that in the next episode. If breathing is inadequate, this is where you start thinking about assisted ventilation. But for a civilian responder, this most likely means recognizing the problem and communicating it to the incoming EMS. Let's move on to C, circulation. This is where we talk about the signs of shock. We're looking for things like skin color, capillary refill, mental status, pulse quality. Is there internal bleeding you cannot see? Probably yes. You keep them warm, you keep them flat, and you prepare for deterioration. Okay? So we move on to H. If you have a high mechanism collision, you should assume that the head struck something, potentially the windshield or the dashboard. Now, Assuming that there is a head injury, you don't want to move the neck unnecessarily. And you keep them warm because trauma patients cool fast, and hypothermia in a bleeding patient worsens coagulopathy. 5 letters, 5 checks in order, always in that order, unless you find something in an earlier letter that you have to solve before you move on. That's the algorithm applied to a real scene, not a checklist. It's a priority hierarchy. The difference matters when the patient has 3 problems at once and you only have 2 hands. Now, what are the 3 takeaways from this episode? 1, March is a priority hierarchy ranked by time of death. M kills in 3 minutes, A in 6 to 10, R in 10 to 15, C in 30 plus, H in hours. The order is the math. 2, massive hemorrhage before airway, always on a trauma scene. Any civilian training that puts airway first is inverted. Fix the bleed before you touch the head. 3, the letter is a category, not a step. When you hit A, you're asking a question. Is the airway a problem here? Right? You're not performing a ritual. If the answer is no, you move to R. The algorithm is a decision tree, not a script. Next episode, we stay in R, respiration. Specifically, we talk about chest seals, right? What the package doesn't tell you, and why vented versus unvented is a decision that matters more than most civilians realize. Stay tuned, and I'll catch you next time.